Hello everyone and welcome to Crash Course Medicine. My name's Emily and today I'm going to be talking about cystic fibrosis. To begin with, let's go through some questions to see what level our base knowledge is at. Question 1. Which of these organisms does not commonly cause respiratory infections in patients with CF? A. Aspergillus, B. Pseudomonas aeruginosa, C. Staphylococcal aureus, or D. Strongyloides stercoralis. Which of these normally cause respiratory infections? The answer is D. Strongyloides stercoralis. This causes threadworm, which is not a respiratory infection. Question 2. What is the mode of inheritance of CF? A. X-linked dominant, B. Autosomal dominant, C. Autosomal recessive, or D. X-linked recessive. Would you be able to inherit CF if only one parent was the carrier? The answer is no. Both parents need to be carriers to inherit the gene. It's carried through autosomal recessive. What is the normal function of the cystic fibrosis transmembrane regulator? A is a chloride channel, B potassium channel, C water channel, or D sodium channel. Which ion or molecule is transported through the channel? The answer is A, a chloride channel. Chloride is transported out of the cell into the covering mucus. Sodium ions follow passively, resulting in movement of water out of the cell via osmosis. Question 4. Cystic fibrosis is caused by a mutation on which of the following chromosomes? A. Chromosome 17, B. Chromosome 5, C. Chromosome 6, or D. Chromosome 7. In the UK, 80% of CF cases are due to delta F508 on the long arm of chromosome 7. So today we're going to be talking about cystic fibrosis. What is cystic fibrosis? Symptoms, risk factors and history, investigations and differential diagnosis, clinical examination and OSCE tips, treatment, and then finally we're going to go back over the previous questions to see what we've learnt. So what is cystic fibrosis? Cystic fibrosis causes mutations in the cystic fibrosis transmembrane conductance regulator, or the CFTR gene, which codes for the CFTR channel. It's an autosomal recessive genetic disease. Mutations in the CFTR result in abnormal salt transport, resulting in thick, sticky secretions. This can cause problems in the GI, respiratory, and reproductive systems. Cystic fibrosis affects 1 in 2,500 births. In the UK, 80% of cystic fibrosis cases are due to delta F508 mutations on chromosome 7. CFTR mutation classes. There are 5 different classes of mutation. As you can see here, the normal transport membrane protein is functioning correctly. Class 1, the CFTR is not created. This happens in about 22% of people with cystic fibrosis. The treatment is read-through compounds which allow the production of CFTR. Class 2, the CFTR is created but misfolds, keeping it from the surface. This is the most frequent of all of the mutations. In about 88% of people with cystic fibrosis have this. You can treat it with lumacaftor or tezacaftor, which can fold CFTR correctly. Class 3. The CFTR is at the surface, however the gate does not open. This occurs in around 6% of cases. Ivacaftor can help open the CFTR channel and increase function of normal CFTR. Class 4. The function of the channel is faulty, however it is at the surface membrane. This is 6%. And can be treated with ivacaftor as well. And class 5 is normal CFTR, however it's in insufficient quantities. This is the most rare and happens in around 5% of cases. This can also be treated with ivacaftor. The pathophysiology. In the pancreas, there can be blockage of the exocrine ducts. This can lead to early activation of the pancreatic enzymes, which can lead to autodestruction of exocrine pancreas, leading to pancreatic insufficiency. People with cystic fibrosis therefore normally have poor absorption of lipids and lipid-soluble vitamins A, D, E, and K. In the intestine, in the meconium ileus at birth, the meconium is thicker and stickier than normal, creating a blockage, and intestinal obstruction later in life from bulky stools. Chronic inflammation, scarring, and strictures may also occur. In the urogenital system, bilateral absence of the vas deferens is normally noted, with mucus clogs as they are forming, causing them to deteriorate, so the patients are usually infertile. The lungs, mucus retention, chronic infection, and inflammation which result in eventual destruction of lung tissue. Symptoms and risk factors: meconium ileus at birth, failure to thrive, voracious appetite, wet cough, recurrent chest infections, steatorrhea. Risk factors: family history, ethnicity, white, known carrier of both parents. History. Let's take a look at a case history and see if we can pick out the key points. A 1-year-old child presents with failure to thrive. By history, the child was born at the 50th percentile for weight, but has decreased across multiple percentile lines despite having a ravenous appetite. The child has more bowel movements per day than other children of the same age, and the stools often look shiny and have an unusually foul smell. In addition, the child has been treated with multiple courses of antibiotics for a persistent wet cough. Investigations. Sweat test. This will be positive if sweat chloride is greater than 60 millimoles per litre. Immunoreactive trypsinogen test. Genetic testing, the presence of 2 disease-causing mutations. Differential diagnosis. Primary ciliary dyskinesia. This is not associated with pancreatic insufficiency. Patients with PCD may have chronic middle ear infections which are also not associated with cystic fibrosis. Primary immunodeficiency. This is also not associated with pancreatic insufficiency. You can differentiate this by measuring the lymphocyte, neutrophil, and immunoglobulin levels. Asthma. This is not associated with purulent bronchitis or digital clubbing. However, patients with CF may also present with asthma. GORD. This is also not associated with signs of malabsorption. Clinical examination. The patient may be tachypneic, have wheeze or crackles, cough, increased anterior-posterior diameter of chest, clubbing, cyanosis, hyperresonant chest upon percussion, abdominal distension, and nasal polyps and sinusitis. The treatment: chest physiotherapy, inhaled bronchodilators such as salbutamol, inhaled mucolytic, Dornase alpha. Optimizing nutrition for the patient is really important. Pancreatic enzyme replacement if needed, oral antibiotics for the recurrent chest infections, and eventually a lung transplant. OSCE tips. CF patients are often Caucasian, younger, and have short stature and low BMI. There may be some clues around the bed, such as sputum pots, inhalers, a nebulizer or NIV machines, physiotherapy devices, nutritional supplements, and insulin pens. They may have a gastrostomy tube in the abdomen. They may have clubbing, and they will often have coarse inspiratory creps on auscultation that might clear on coughing, which is consistent with bronchiectasis. They may also have a wheeze. So in summary, what have we learned? Let's go back over the previous questions. Question 1. Which of these organisms does not commonly cause respiratory infections in patients with CF? Aspergillus, Pseudomonas aeruginosa, Staphylococcus aureus, Strongyloides stercoralis. The answer is D, Strongyloides stercoralis. Question 2. What is the mode of inheritance of CF? X-linked dominant, autosomal recessive, or X-linked recessive? The answer is autosomal recessive. Question 3. What is the normal function of the cystic fibrosis transmembrane regulator? A. Chloride channel, B. Potassium channel, C. Water channel, or D. Sodium channel? The answer is A, chloride channel. Cystic fibrosis is caused by a mutation on which of the following chromosomes? A, chromosome 17, B, chromosome 5, C, chromosome 6, or D, chromosome 7? The answer is D, chromosome 7. That's the end of the slideshow. I hope you found it useful. Please come back to Crash Course Medicine for more revision materials. Thanks a lot. Bye.